Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your co-host, George Marcellus.
George, it's nice and sunny in Melbourne. Is it sunny in Sydney?
It's been muggy, but the sun's been out. It's been a bit weird. We had a little bit of rain, a little bit of cold, a little bit of heat. We can see summer's coming along, and we're watching the weather reports in the morning tells us that it's going to be another hot summer this year. So climate change may be more realistic than some major politicians believe in.
I know, God. My ears have been full with political podcasts in the last week. What have you been up to, George?
Same as you. I mean, I've managed to get a way of watching multiple US news programs at the same time. So I had the great pleasure of watching President-elect Trump accept the position on both MSNBC and Fox. And it's really interesting watching two very disparate descriptions of the journey. But now it's been a good couple of weeks since we last time we were together. I had the pleasure of going up to Brisbane, representing Pulse IT with my reporter hat on, as requested by Kate, at the AI Revolutionizing and Transforming Community Care event. And that was quite an interesting event, about over 100 people looking at a range of AI topics as they related to aged, community and disability care. There were providers there were developers there was few academics, some interesting stuff. But the main message was basically that the sector, like every other sector, has to prepare for AI, whether they like it or not. It's there. It's going to become part of the way we deliver care going forward. And unless we actually get involved in it, we won't be able to utilize it. But we do need to adhere to those privacy restraints and understand the issues and the consequences. Toby Walsh, who I first met at MedInfo last year, gave a rousing presentation about the future of AI. I mean, he's published a whole number of books on that space. One thing he did focus on, and I thought was really interesting when we started talking about the monetization of generative AI. At some stage, these companies are going to have to make a buck out of this. The infrastructure behind these systems is huge.
Oh, yeah, the cost.
How are we going to do that? And he suggested that maybe it's that classical, we may not be paying for it in cash, but we may be paying for it in other ways model. So he suggested maybe generative AI will just be a much more efficient way of making sure we buy what people want us to buy. So that was a bit scary, but good presentation in itself. I did spend a couple of early mornings staying up for the Digital Health Society Summit, which was hosted by the ECH Alliance. Again, lots of focus on AI, on quality of data, how important that was. And that fits in well because one of the presentations at the Brisbane event was by a guy called Dr. Evan Shelshear, who's just published a book called Why Data Science Projects Fail. And he looked very much at that issue of the quality of the data is critical, understanding what you want to get out of the data is critical, and just throwing things and getting an AI answer doesn't necessarily have value if it tells you to do the same thing you're going to do anyway or doesn't provide you with a clear answer. So I've got a couple of AI events this week, so I think the last 2 years would have been very boring if AI hadn't been around. That's keeping us very busy.
I'm sure we would have thought it was something. And you've got some big personal news, but I suppose that'll be hold off for the next episode, and you've got some more concrete. We can just tease people with it now.
Absolutely, absolutely. How about you, Louise? Have you recovered from jet lag and come back to the world of Australian digital health?
Yes, and very pleased to see the US election. They have been calling the election the podcast election because if you look at the technology enablement of speech and advertising and how do you get your message to the people who are voting or you're trying to get them to vote, there was a time where it was only television ads and newspaper ads, and then it became advertising on Facebook and then Twitter. And this election, I like the idea of the podcast election. I was thinking, which channel do I tune into? And in the end, I tuned into The Rest is Politics. They did 8 hours of coverage and, it's an excellent podcast with Anthony Scaramucci and Alistair Campbell, Rory Stewart, and a couple of others from their sister podcasts. So anyway, I had a great time listening to those, but I was like, this is a good thing that we're doing a podcast. There's more and more people attracted to podcasts, listening to podcasts while they go about their daily lives and, educating and hopefully being entertained as well, depending on their interests. And what else? Oh, I've been helping a company launch a new business. So I went in and they had an idea for one business, but we've pivoted and we're going to be launching a new business. So officially in the next couple of weeks, that will be done. And it's been a really great exercise working with a great group of people and to see how you can suggest, how we were going in this direction. I think we should go in this direction instead. And when you're working with startups, instead of people freaking out and going, no, you can't do that, to be honest, it was easy. We all went, yeah, that actually makes sense. And so I've pivoted the whole company to launch soon. So that's been really fun.
Excellent. I'm looking forward to learning more about that, and sign me up as a customer.
Oh, thank you, George. Well, hey, one thing I have to report on now, regular listeners know that we have covered a couple of episodes ago, Apple AirPods being able to be used as hearing aids and hearing devices now. So anyway, Amazon had a sale. Ryan, my partner, got very excited. We actually bought the AirPods while we were in the States traveling around. And my brother-in-law in the States, when we were hanging out with him, we told him about this, and he's in a certain demographic, which means his hearing is not as good as it was when he was a younger guy. So anyway, he did it in front of us and he's like, oh my God, this is a game changer. Anyway, so Ryan tried his this weekend, got all excited. And yes, I have an apology to make for anyone who listened to Pulse Pod and thought this is a good thing and they went out and did it if you live in Australia, because that feature is not available in Australia. No, it hasn't been approved. I think there's listeners of Pulse Pod in over 50 countries now. And rest assured, if you are not Australian, if you're in all of our other listening countries, I checked, they're all on the list, but not Australia. So we still have to wait for some time, unfortunately, George. So I'm still going to have to be yelling at Ryan in restaurants and him pretending he can hear what's going on and he really can't.
Call out to Apple Australia. You're missing out on the most lucrative market. Men who don't want to listen are a critical element here. So get it happening.
Yes. Well, and I looked online and I found that there's been so many complaints to Apple and to the TGA. And the TGA, someone actually cut and pasted their response that they got back from the TGA. It was, very politely worded, as you would expect government to be, but they did clearly state that it's a medical device, so they need to give approval to devices like that. And they could neither confirm nor deny if they were currently processing an application because of commercial sensitivities. But, just stay tuned, I guess.
We'll keep an eye open for it, but we'll actually our ears open for it.
Yeah, exactly. All right, let's get to our hot topics then, George. I don't know what your thoughts are. Now, I haven't actually taken the step of deleting my Twitter or X account, but I do often think about it because I rarely look at it these days. It's so much of the valuable content I used to get, it's just simply not there anymore. However, in my feed, I recently did spot something interesting, which I thought I'd raise on the pod. So Elon Musk sent out a tweet stating that his AI, which is called Grok, Grok, is ready to analyze medical images, stating that while it is early stage, it's already quite accurate. He invited his 204 million followers to submit their images for analysis and to let him know where it gets it right and where it gets it wrong. Now, much to the horror, I'm sure, of all the privacy advocates listening that spend their lives ensuring or at least trying to do everything possible to protect patient privacy, that post has had over 8,000 comments on it. Many of them are images of people sharing their medical images and some sharing results of analysis of their blood test results too. There's lots of examples of the basic errors it's making, including one of my favourites, confusing a breast cyst with a testicular ultrasound. Now, I won't be putting a link to the post in our show notes, but I do warn anyone who goes to look for this, if you haven't seen it, there's also unfortunately plenty of quite juvenile dick jokes in response to that post. But George, it is clear that Elon needs access to medical images to train his AI. But instead of actually going through maybe some more ethical but potentially slower channels to get them, he thought he'd just crowdsource these images by telling people it's already good to go. Now, of course, people are free to share their data with whomever they want, but the medical regulatory authorities are not pleased with this, but they can hardly keep up. What are your thoughts?
Sharing your x-rays with Elon, what could possibly go wrong with that? Seriously, considering the discussions around the world about privacy and social media, it does take quite a unique type of individual to suggest, hey, whilst you're sharing stuff on social media, show me your breast cysts and your testicular torsions. And what could go wrong with that? You would have thought at least he would have, renamed the service. So Grok, at least call it Dr. Grok. So if you're sharing it with Dr. Grok.
Oh, that actually sounds quite good. Dr. Grok.
But then again, I guess if he really wanted to make it work, and he seems to have done this in the past, if he included a lottery where you could win $1 million to share your images online, that may drive a lot of things. But seriously, it's just such a huge breach of privacy, such a risk But then again, he has been called a super genius by the president-elect. So maybe we're wrong, but I'm not willing to put my images up yet. And I will just state what the Medical Board of Australia sent to me and every other doctor in Australia recently. Do not upload sensitive medical and personal information into public large language models. Full stop.
They couldn't get any clearer than that, could you?
Yeah, it's like I said, whilst crowdsourcing all sounds great, these sort of information can really lead to some really big privacy breaches that people just can't recover from. And to your point, taken my Twitter handle off my email address a while ago now, and I very rarely go on Twitter or X. It's really lost that value of being a real-time information source.
Absolutely. It's a shame because it was so valuable. But anyway, I think for me, I just saw the post and thought it was hilarious because I was like, oh my God, of course, he's just going to crowdsource rather than get the images in more ethical ways. But it's interesting that the general populace may not actually understand that we really need scientific validation before models are available to the general public. And if they're not ready, they should at least be said that, hey, it's not ready yet, but if you want to help me build it, or like you said, there's $1 million lottery, I'm sure a lot of people would donate their images and good luck to them. But yeah, the idea stating that it is accurate when it's clearly not. And people seem quite confused. One, clearly, George had a knee replacement because, like metal in your body shows up as a solid. And Grok's assessment was that a knee replacement is required. It didn't actually pick up on the fact that it's already been done.
They meant the other knee. Yeah.
Oh, yeah, maybe.
Maybe, yeah. It's predictive, It's predictive AI at its best. Look, companies like Harrison AI are doing a great job in using radiology and artificial intelligence together. And we've seen some great examples how it can work, but this needs to be done in an ethically sustainable way.
All right, well, on to our next hot topic. Now, listeners to PulseSpan, I did say earlier, span over 50 countries. And there are a number of things that our countries have in common, aside from the growing community of people interested in digital innovation in healthcare. And that is, there's not enough health professionals everywhere. Countries are grappling with what to do about this and how do they get more healthcare professionals. Importing them seems to be a common policy position. And I know, George, you like to use the Pulse Pod to be a quasi-recruitment source for all health professionals and digital health specialists to move to Australia to live and work. But the other workforce strategy is not just how do we get more healthcare professionals, but how can we make better use of the workforce we've got and make sure that people are happy and fulfilled so that they stay in their jobs. The Australian government has just released a report reviewing the scope of practice of Australia's healthcare professionals. There was 18 recommendations, and amongst them were 4 that relates to technology. One was direct referral pathways supported by technology. So the idea there is that instead of your GP being the only healthcare professional that can refer you to a specialist, other healthcare professionals can as well. But technology would keep everybody in the loop, improve the communication, notify relevant team members. Another recommendation was about changing business models of healthcare with a blended payment model, and underscoring that is digital infrastructure requirements. So you would get paid differently, but you would also have to use technology such as secure messaging, event notifications, and of course, integration with My Health Record to ensure that information flows smoothly across the team. Another one was capacity building and implementation support for primary health networks. So the idea is support for primary health networks to help them support the integration of tech into clinical governance, risk management, and quality assurance processes across primary care. And technology-enabled co-design with consumers was another recommendation. So it's great to see the emphasis on technology as an enabler for effective communication amongst health professionals to enable them to do their jobs. I don't think, George, you or I would disagree with that much, but have you had a chance to look through the report? What are your thoughts?
Look, I have, and it's had quite a lot of visibility in the professional press as well about what's come out of the report. So the Unleashing the Potential of Our Health Workforce, as it's so ably called, is an interesting reading. First, I'll make a bit of a personal observation. Many clinicians I know are working well below their scope of practice, but at the same time, many are working well beyond their scope of practice. So it really is a heterogeneous workforce out there, some who get by doing bread and butter and some who do some really complex stuff.
Hey, George, can I just ask you to clarify? So when you say beyond or below their scope of practice, do you mean what is formally defined as their scope of practice or the abilities and skills that they have?
I think it's the abilities and skills they have. Yeah, it's a combination of both. So, for example, a lot of general practitioners are happy to manage repeat prescriptions, refer out without getting too overly engaged in therapeutics and diagnostics, whereas others will dive deeply into that and look into the intricacies of the diagnostics and be actively involved. Same goes with a lot of my allied health workers. I mean, optometrists are a great example. Some optometrists will just prescribe you glasses and contact lenses and do a perfunctory examination of your eye. Others will get involved heavily into the clinical management of eye disease. So there's all those sort of characteristics. But one of the things I've always noticed is that trying to get people to work at the highest level at all times is what often leads to burnout. I was at a presentation recently where someone used the racehorse as an example. Racehorses are something that we work on to make sure they work at their maximum potential, but we don't get them to race all day and all night. I mean, we make them focus on times when they can do that at its best, and at other times do different things. And we have to sort of think about that when it comes to healthcare professionals as well. I mean, if every day, everything you see is a life and death case and you have huge responsibilities around it, it probably can lead to burnout. So just getting the workforce to work harder is probably not the right solution, but getting them to work better is great. So I looked at the report. I'll be honest, the technology perspectives I thought were a bit disappointing. They really just focused on a couple of enablers of things rather than thinking about how they would use the technology to change things more specifically. No mention of AI at all as a tool for supporting clinicians, nor the role of the consumer and education in developing a stronger therapeutic relationship between providers and consumers. We've spoken about it a number of times in the podcast that a well-informed, enabled consumer is probably the greatest asset to their own healthcare than any clinician is. So getting them actively involved is critical. Blended care payment models, been there, done that. We've had that discussion for many, many years. Sure, we can facilitate the payment and the payment models. I'm old enough to remember when Medicare payments required us to have a special Medicare card, which we put through a paper swipe that we could imprint, and then we had to mail them to Medicare once a week. And 6 weeks later, we would get a check back in the mail, which we would deposit in our bank accounts. But I think we need to start thinking outside the box a bit. And in future, will not using AI mean that you're practicing below your scope of practice? Because AI would be the enabler that maybe gives you that little bit of extra zing to deliver better care.
I agree with you completely. I was really pleased that it got there at all. I mean, we've had so many government reports over the years that come out. You just do a control find for words like technology, computers, telehealth, and, they're rarely there. So it was good that it was there. But yeah, just saw it as an enabler using quite outdated technology. So the idea of using technology as an enabler to be different, to deliver care differently, to work differently, I thought was an opportunity missed. But there's a big role for digital health in enabling role convergence. And that's something that I think could be looked at more seriously as well.
Absolutely. And look, that requires us to really rethink the whole way we train our clinical teams. As we talk about team-based care, we need to train people around facilitating team-based care, not just being a component of the siloed care within a team, which is where we currently sit.
Yeah, that's right. Well, our next story, George, is also about technology improving communication. Nature Medicine just dropped a fascinating piece about the role of health tech in war zones. The piece looked at how clinicians are teaming with tech companies to develop digital tools for tackling the challenges they face and bridging the gaps in care caused by conflict. Some of the examples were really interesting. Doctors using AI chatbots to learn battlefield medicine, telemedicine connecting specialists across continents. There was an example given in the piece in Ukraine. 60,000 remote medical appointments have been conducted, electronic health records to keep track of refugee health data, medical drones to deliver medicines, vaccines and other supplies. Although the article did note that now in Ukraine, those drones are grounded due to the no-fly zones. And in Syria, American doctors treating ICU patients through WhatsApp. And the article got us thinking about designing for disaster. So, there's an infrastructure required for all of this tech. There's technology infrastructure, communications infrastructure, electricity, power infrastructure. Potentially, when we figure out how to deliver healthcare in these extreme conditions, there are lessons there on how to make our own healthcare systems more resilient and innovative. It's also a great role for healthcare innovators here, albeit not necessarily the ones you're going to see at your local pitch night event. What are your thoughts, George?
Look, that article did catch my attention, and I have to give a shout out. I do quite like Nature Medicine. They have a digital medicine publication as well, which is really good to see. And it does go into quite a bit of depth. It really is relevant today. I mean, we've seen the difficult times we live in, the carnage with the various theatres of war, which are quite horrific. And I have to say that when I was a younger person, I used to love MASH, was one of my favourite TV shows. So that delivering medical care in the theatres of war was always fascinating, although I have to say it never actually enticed me to try it, but I did love watching it on TV. And Hawkeye Pierce is still one of my role models as a doctor. The discussion about whether military applications drive innovation is interesting. I was in the US a few years ago, and DARPA, the Defense Advanced Research Projects Agency of the United States Armed Forces, had a stand. I think it was at the HIMSS event back then, and they had some really cool stuff. So this was 12, 13 years ago. They were showing these amazing telemedicine kits that packed up into a bag, were resistant to bomb blasts, worked on very low bandwidth, had the ability to plug in pieces of kit that didn't exist anywhere else at the time. They could show things like delivering supplies using that famous robot dog being used to deliver blood supplies. But the really interesting thing was they sort of kept on highlighting that at the point of care, you can't determine who's going to be there. I mean, if you're lucky and the guy next to you is a doctor or a nurse, that's a great thing. But if the guy next to you doesn't have those clinical skills, they're the only one there to provide that care. That real-time training and support tools to enable frontline soldiers to become literally medicos on the field was critical. And they showed some really good examples of how they were doing that in real time back then. The prices they were paying for these things was astronomical because of the fact that everything had to be triply redundant and work under amazing situations. But that sort of stuff trickles down into the community. So as we see going forward, the fact that they're doing these sort of things in military fields is fascinating. And then at the same time, they actually had a team there from NASA talking about how NASA delivers care. And again, leveraging some of the technologies out there and then taking those learnings and delivering them into the community, I think are really critical. It really does show that we need to focus in on as many opportunities for innovation as we can. And whilst war is a terrible indicator for us to have to work towards, that's the reality. However, I did work many Saturday nights at RPA, and sometimes that was a bit of a war zone. So sometimes that would have been handy to have some of those battle armaments back then as well.
I agree with you. I mean, NASA's been using telemedicine for ages. You can't really do in-person care when you're actually literally not on the planet. And I remember a guy who I think he consulted with NASA, met him years ago at a conference, and he actually consulted on the James Bond movie when the franchise got rebooted with Daniel Craig and Casino Royale. And I'm sure all Pulse Potties would have seen that. If not, please go and do that. That's your one homework exercise from today's pod. In it, there's a scene there, so small spoiler alert, but there's a scene where James is poisoned and he has to rush to his car. And there's effectively like this telemedicine kit in his car where someone is talking him through what he has to do to not die in the next 60 seconds. And this doctor actually consulted on that scene and made sure it was realistic as possible. I like the idea too that because technology has evolved so much and it is so everywhere, even though we might not think it's everywhere as much as it could be in healthcare, that there are non-military applications being used and non-military innovations. So just, going, well, hang on, how do I connect with people in Syria in the ICU unit? Well, WhatsApp, let's just use that. Not regulated as a medical device, not regulated as an official communication channel, but hey, if it works, we can help people, then why not?
Absolutely. And like I said, we can't always be guaranteed electricity. We can't always be guaranteed high bandwidth. So tools that take advantage of other options are interesting. But hopefully the learnings from there will flow out. But hopefully we won't need them in wartime and we'll be able to use them much more effectively in peacetime as well.
Yes, absolutely. All right, well, George, our last hot topic, I think it's a really good news story. It's a happy day when there is a new treatment for cancer. And this one is very digital health. In the US, the FDA has approved the very first wearable that kills cancer cells. The wearable basically emits electrical signals that are delivered by wearable patches, which you wear directly on the skin, and the field of electricity kills the cancer cells as they divide. Healthy cells are not impacted. This specific device is for a specific type of cancer. It treats adults with metastatic non-small cell lung cancer, and it's used after you've already had chemo. But still, this is just a big step in the right direction, I feel, to have this new way of identifying and killing cancer cells. What are your thoughts?
This is really exciting. Oncology is a really, really complex area, and anyone who has lost a loved one to cancer knows it's very close to the heart. Couple of disclaimers here. My mother actually did pass away from non-small cell lung cancer quite a few years ago. My nephew, 34, passed away a couple of years ago from a very aggressive type of sarcoma. So understanding the science of oncology and understanding how we can treat it is critical. Another disclaimer, my eldest son actually works in the oncology clinical trial space. So I've had quite a bit of exposure to this. The problem has been that oncology is really, really complex. I mean, it's a genetic disease that's facilitated by proteins and receptors, and it's just trying to understand it. And the other thing we're discovering is human biology is a lot more complex. So understanding other facets of science, in this case, electromagnetic energy and how they can interact with cancer drugs. In this particular trial, they combine a cancer drug with the electromagnetic field to improve its targeting. I think it's really important. It means we need to think outside the box. We need to get researchers in place that go beyond just the classical medical training. And we saw this year's chemistry Nobel Prize going to a deep mind around how we use technology to understand protein structures. More of these stories. I hope Australia can play a key role. And look, Australia does play a huge role in this research space. So I think you really should also highlight the fact that many of our Australian organisations do a great job in this space. But this really is core area. We're now starting to see cardiovascular disease drop from being the primary cause of death and cancer becoming the primary cause of death. So we're actually seeing shifts in the mortality figures around oncology. And it's a wicked problem. It's really a hard one to solve. And the more innovation we can bring into this space, the better.
Yeah, I think it's amazing. Yay, science. And, that's one of the things that, again, people were talking about at HLTH, was actually the promise that AI, you look at the protein folding stuff, Nobel Prize, no small endeavor there, but actually being able to have this availability to collect data and compute data to give us insights. I'm certainly hoping in my lifetime cancer can be turned into a chronic disease, even if it can't be completely cured.
Yep, I think we all sort of agree on that.
All right, well, after this brief break, we will be back with our special guests of Pulse, Honor McGon and Robin Mann. Today, we have a Pulse Pod first, ladies and gentlemen. George and I are talking with two people at once, but we still have to stick to time. Luckily, none of us, especially me, suffer from being verbose, so I'm sure we were up for the challenge. At the beginning of October, Pulse IT published an opinion piece entitled How a World-Class Health Information Exchange Could Be a World First. The article was hugely popular, generating a lot of traffic, so we thought we should invite two of its authors for a deeper dive. Dr. Robin Mann is trained in both engineering and medicine. He worked as a doctor in the UK, established the Health Informatics Unit at the Royal College of Physicians in London, and held digital health leadership positions in Wales before moving to Australia. He's been in Australia for a long time. Many of the Pulse Poddies would know him. He's worked for many of the Big Four consulting firms and has led Fujitsu's health consulting practice in Australia and New Zealand. Joining Robin is Dr. Honor McGon, who made headlines in Australia in 2022 when she won the prestigious Fulbright Scholarship to study clinical informatics at Stanford University. Honor's LinkedIn profile says she seeks to push the boundaries of what a medical degree can provide. Love it. Honor is still in California and is the medical director of a startup that spun out of the School of Medicine at Stanford. Robin and Honor, welcome to the PulsePod studio.
Thank you.
Thanks for welcoming us.
It's really great you could join us.
So for the Pulse Poddies, for whom HIE or Health Information Exchange is an unfamiliar term, what is a Health Information Exchange and why did you pen this opinion piece?
Yeah, so a HIE is a collection of services, technologies and interfaces that allow health information to move securely between providers and patients. In other words, it's a way of being able to exchange data between different organizations.
Why did you two and your co-conspirators get together and write this opinion piece? What inspired you?
So I guess for me is you always start with the problem that you're trying to solve. HIE can bring data and information that can support people making better decisions about someone's care, for example. So you could be better informed. That's largely the argument behind systems like My Health Record. If you can see someone's history, then you can make better decisions. But data can also be used to drive data analytics and AI and these other tools and provide visibility where previously you didn't have it. So that can be useful particularly to help keep people healthier at home and keep them well. But the problem that we need to solve is actually one of rising demand. We've also got the problem of an aging workforce, and post-COVID, we've got the problem of burnout. So we've got a diminishing supply of people to provide for an increasing number of people, and data and analytics, and therefore the HIE can help to serve. And my feeling was that conversation is not really happening at the scale it needs to in Australia yet. So that's why I thought we should write an article about it. And that's why we gathered the co-conspirators together to write a piece that we hoped would draw some attention to the opportunity that this presents.
Yeah, I just wanted to add on as well. I think that there's been a lot of talk in the physician wellbeing space, like the problems that are occurring, such as high rates of mental health issues within a medical workforce, but we don't talk about systemic changes. And there's a lot more of a change in the discourse in the physician wellbeing space to talk about our systems. So from a physician wellbeing point of view, let's reduce information foraging, which is a term that I might throw around a couple of times today.
I love it.
I love the term as well. It's great. In order to be able to systemically improve the lives and well-beings of clinical staff, physicians, and everyone else.
It's a really good point. It's always struck me as completely insane that we have these clinical professions, many of which have to make these really tough decisions day in, day out. They have a really tough job. And then we don't give them the adequate systems to do the basics of that job. It's crazy that the system would work the way that it does.
100%.
One of the big challenges we had with the introduction of electronic medical records was that extra click overload, which made us all very antagonistic to the systems. So you've painted a very compelling picture here, what the HIE can do. And the promise is very exciting. But to be honest, putting on my grumpy old doctor hat again, I've heard it before. We've had solutions come in which are going to revolutionize the way we deliver care. And 5 years down the track, we've seen all the unintended consequences of the implementation. HIEs in themselves aren't new. The Americans have been working on them for ages. What's going to stop this from just bogging down in that classical bureaucracy of my API can't talk to your API, you need to change your API, and you're using the wrong standard, and all those continuing debates we keep on having in the digital health world?
Well, you've got to say sparked, don't you? It's got to be a solution to everything. No, look, in seriousness, and I think it's driven out of the US and Medicare Advantage and the policies legislation that has generated the demand for fire resources. And of course, we can't say the word fire without mentioning Graham's name and the genius behind that. So technologically, the solutions are there and they're maturing. And we obviously are a very active community at the moment working on fire standards, both from clinical and technical worlds and health informatics standards. This is showing great progress, a huge amount of momentum behind it. So from a technical point of view, there aren't really any major obstacles. Bureaucratically, there's obviously momentum building. It's a huge step forward that governments are signing up. There is a point in time where the risk of doing nothing becomes more than the risk of doing something. And that drives a change in the community practices, the stakeholders. People will become behind an initiative which is going to solve a whole bunch of problems. That process is happening now. There are a whole range of vested interests, different players incentivized by different things. But if we can get people to focus on the interests of patients and understand the problem of the rising demand on the health service and that there are opportunities for all the players in this space, then I think that starts to move that along.
So you're saying that you're really seeing a cultural change, that it's not just technology ready, but there's a cultural shift that's been happening. That is why you think Australia's ready for this now?
I think that cultural shift has been happening in people's minds for some time. Any conference for the last 5 years, you'd hear about people expanding the need for data sharing, the challenges of different funding models that exist in healthcare, different people worried about their particular parts of the puzzle. But overall, there's a movement towards more holistic care, towards patients, keeping people out of hospital and servicing that. I think the HIE is a fantastic initiative in that direction to enable and support that.
Talk about cultural change, and we've seen obviously leadership change as well. So we've got now health ministers, both federal and state levels, who are big supporters of digital as tools going forward. The one roadblock we've always tended to have are the clinicians. The clinicians say anything that adds to their workload is something they're averse to doing. So with My Health Record, generating care summaries was something that GPs just didn't bother to do. Does HIE add to the workload of data entry for the clinicians, or do they basically just do what they normally do and the HIE swoops up that information and shares it more effectively?
What could happen easily is if you provide access to all this information suddenly to people, then they're expected to look at all that information. It's not the documenting that takes additional work that is the burden. It's actually the need to look at everything. So what's important is the way that information is presented to people.
I mean, this is right in my wheelhouse because as a junior clinician that came on at Queensland Health right when paper was transitioning to IEMR, that's what I witnessed and experienced firsthand. The information foraging, this like trawl through all the information that we'd been given access to was just such a sore point. Simple functions such as just being able to do a keyword search was really slow within the system that we had available to us. And consequently, our call to action is saying, hey, HIEs are really important. But what it facilitates is this push towards developing tools that will enable clinicians to be able to find the right information at the right time for the right patient. And what we really hope with being able to provide access to so much more information as well is inspire some thought around, from particularly private industry and startups, like what else could we do to help this information foraging service, for instance? How can we help the clinician look for that echo that the patient thought that they had some 5 odd years ago? And I think that there's some really interesting companies working in this space that are plugging on top of the information providers, the EHRs. HIE is just the first step in developing our infrastructure to then inspire and build further tools on top of that.
I'd actually go one step further than that. It's not just about finding the information that you want quickly. It's also about the system being able to present the information that you need at the right point in time. It's about being presented that information. So years ago, I worked as a CIO for one of the not-for-profits here in Australia, and we identified surgical workflows where the surgeons were really interested in before the procedure, very different information to after the procedure had been done. So we looked at the recovery period post-operatively and were able to identify patients that weren't recovering from their procedure as expected. And maybe they could have gone to renal impairment or renal failure because of the procedure. This is quite a common occurrence. So we were able to then notify the doctors on a mobile phone that their patient was deteriorating as soon as the information was available, so they can then take action. So the surgeons wasn't going to look for that information. They were actually being told something was up and we should take action here. So that specific types of use case is really important. If you understand the patient's journey, the clinician's interests, what's important to that, the efficiency of that care and the patient's well-being as they traverse through various stages within their care journey. That's the kind of thing a HIE should be able to support in the future. That type of analytics behind the scenes can then drive better outcomes for patients.
Yeah, make it seamless. So we could actually look at an HIE playing a role in reducing healthcare demand for services, especially those services that provide low quality care or expensive care that actually is only necessary because we didn't act early enough. So how do you envisage this could work for the complicated mix of public, private, state and federal players?
Yeah, so I want to take a bit of an optimistic slant on this. I think that this should be a win-win for all players because if you reroute money from expensive, unnecessary admissions towards more effective service provision, you then have more money in the overall pool to invest in other things as well. The public, private, state and federal players do need to think about other ways they integrate technology into their systems and consider the fact that they might also be leaving something on the table by not acting. For instance, you want to ensure that you're planning as a healthcare organization for some sort of data strategy to be able to either query your own data to generate funds through research grants and things like that, or potentially even have some sort of data sharing agreement for the purposes of research or to private industries to inspire more innovation, research and development in things such as AI-driven models for healthcare services or other healthcare operations. I would hope that federal and state governments always have their eyes on trying to reduce healthcare costs. So being able to use a good HIE and then provide more access to good quality, meaningful patient data enables our healthcare startups to hopefully train models and algorithms on our homebred data and then potentially sell it internationally as well to then apply and train on their models. We could become R&D hub not just for clinical trials here in Australia, but for other forms of healthcare delivery like predictive analytics.
It is great to see the altruism and optimism of young clinicians. Does the market adapt to that, or do we need to be more proactive to make the market adapt to those changes?
I think this is where our government as a public-private split has a real responsibility to come in here and work in the population health space and generate incentives for organizations and individuals to invest in. Either way, the data is being mined in some shape or form. That's going to happen in the future or now. I would encourage all individuals listening to this to think about, how is my data being stored? We're going to be moving towards a situation where it's going to be used for the purposes of R&D or innovation. So jump onto the bandwagon as a clinician and do your part. I don't have an argument against a fee for service, except for I think sometimes this is where we need the government to step in. That being said, I'm young and possibly a little bit naive. So maybe, Robin, you have some further thoughts from a consultant point of view.
I wouldn't argue that, because Robin and I probably were same as you a few decades ago, having exactly the same discussion. So continue the enthusiasm, continue the optimism.
So Otis thinks that I'm old and cynical. I think I'll take that away.
No.
So look, there's a lot of money at stake here in terms of the cost of healthcare overall in Australia. And the problem of a aging population, the demand for healthcare is going to go up and there's going to be less people able to do it. So it's not as if you're taking away the opportunity from people by redistributing money to better outcomes for patients. I think there is a role for the HIE, particularly in the medium term once it's been established and you have that data, to actually look at the outcomes. So you segment the population, you can understand what drives better outcomes, what doesn't, and then you can start to incentivize those because you've got the data to prove it. And clinicians will generally, in my experience, want to do the right thing for their patients. It's the real world evidence that's necessary, which is what the HIE can produce. I'm equally optimistic, if not quite so youthful.
In Australia, we spend $240 billion every year on healthcare. So if you can save even 5%, like 1%, like the amount of money that could be saved by stopping the things that are harmful or just actually a waste of time, do you see that HIE can help drive this efficiency by collecting data, giving the clinicians insights? How do you see that working?
There is huge opportunity to streamline admissions processes to hospital, to preoperative assessments, get those accurate so patients don't turn up for a procedure and they haven't had the right pre-op treatments, that type of things. When someone leaves the hospital, there's a period of time when there's a risk of readmission, and data that comes out of the HIE could also help to optimize for that, because you can start to see what's happening in the community and you can pull people back or get them treated earlier. So specialists can keep an eye on patients when they've gone home and tell the GP or tell the patient to go and seek additional help if they need it, to prevent further deterioration, which will happen to some people invariably. So if we start to capture data, it's a very simple equation. Activity data drives funding. So we know that patients have diagnoses that are made, they have procedures that are done. We know how long they're in hospital for. We know who is treating them. But what we don't have is information about their outcomes. So increasingly, we're capturing PREMs and PROMs, so patient-reported experience measures and patient-reported outcomes measures, which brings that together. But if you can capture the real-world data of individuals around their comorbidities, so how they came in, what the intervention was, and what happened afterwards, and whether they've recovered or not, and how long it took them, and what it means to them, how they feel they've recovered, as opposed to how someone else thinks they've recovered, then you can start to really get evidence that's really meaningful for the population that you look after. And that can drive research, that can drive other interventions, trialing new products, all sorts of things. It's that data that can drive evidence if it's best practice. Those recalcitrant clinicians that may have been stuck in their ways for years, you can bring those people on board, show them the information, show them that the outcomes are improved, then fix those workflows or that decision support into the system in a way that they would use it again and again.
So one of the things that really excited me about your article was around the concept of using the HIE as a platform for innovation. And whilst we focus very much on the health startups, we've seen a lot of clinician-led innovation over the years as well, which never actually goes anywhere because the system itself isn't designed to manage that. The HIE does provide us with an open standards platform. It provides us for ways to access data that's never been accessible before. How do you see this becoming a platform for both clinical innovation, but also the potential for organizations to trigger off startups that may have commercial opportunities, but ultimately still provide better care back to the Australian population?
It's quite evident. I was recently at the San Francisco pre-health gathering of all these startups who are trying to innovate, and they've all come over to the US to try and commercialize.
From Australia?
from Australia to the US. We have such a small population in Australia that expansion globally is necessary, but we also need a bit more support in terms of the pipeline. And data is a really big part of that pipeline, because if we have rich patient level data, what that enables is healthcare startups can say, hey, let us implement this innovation in your hospital system or even small clinic, and you can measure pre-post data of that intervention so much more easily with interlinked data the HIE would provide. If you wanted to, for instance, assess the effectiveness of a new intervention to encourage patients to get a urine test before their urological surgery, and this is a major pain point for me as a junior doctor, if I had the ability to be able to easily at one click see all the private providers and their urine MCSs. And then I had a startup that said to me, you know what, I can automate messaging out to patients prior to their urological surgery, get their urine MCNS done, and then I can give you the result back. Oh my God, that would have saved me so much time as a junior doctor trying to chase people down to see whether they'd had this urine test before their urological surgery, right? That there could inspire another junior doctor maybe one day to build something with the HIE, show the effectiveness, and then potentially present it as a pipeline, like present it to investors to say, hey, we validated this. And it's a really quick method to be able to validate it as well.
So you think that there's also actual business benefits for these tech companies as well, because it will give them not only a path to market, but a potentially bigger market and a place to showcase what they've done, pilot it.
Yep, absolutely. And you could see that occurring inversely. So someone from somewhere else coming into Australia and saying, hey, I understand that you have really good access to patient level operational data. If we were to pilot something in one of your hospitals, what do you think? And the hospital could pilot it in a smaller clinic or even in a larger clinic and be able to measure data non-invasively, just using the data that the clinicians are inputting on a day-to-day basis anyway to measure effectiveness of that. And the one other point I also wanted to make is for any clinicians who have ever done research, being able to do any sort of retrospective observational research is really hard at present. Having a HIE is going to really enable clinicians to have a 360-degree view of the patient as opposed to just the one-sided hospital-based intervention view that we have at the moment. And we've got companies who are building on top of that data availability at the moment, like my company that I'm working on at the moment, where we seek to accelerate observational research. So I see real potentials in both research and the innovation elements there from having a really robust HIE.
So you've got an action plan, which include setting up a multidisciplinary task force, standardizing privacy legislation, implementing national oversights, providing secure data access for research. Some really specific points around the action plan. The question is, who do you think is best placed to lead these initiatives?
I think that we always need clinician input. There are some very qualified informatics professionals in Australia who have deep experience in healthcare. So I trust that the informatics professionals who are currently leading the helm are aware that they always need the voice of the clinician. I think the additional person as well will be part of this multidisciplinary team, because my answer is fundamentally a multidisciplinary team, is also the entrepreneur, the innovator as well, whether that is clinician or not. I think that they can provide some very valuable insights about the most effective way that data sharing is occurring in different industries. I'd go with a multidisciplinary team, definitely with an innovator of some sort, definitely with a clinician.
Robin, any comment?
The beneficiary of this should be the patient, should be us as consumers of healthcare now or in the future. And therefore, the natural conclusion has to be that no single commercial entity or single state government would be the right group to lead it. To me, it needs to be led out of federal government. That doesn't mean they can do it by themselves. There's definitely scope for health services that have got data, innovative and forward-thinking, would be a major part of trialing out various scenarios where these technologies used, would be incredibly productive to help show others what's possible and maybe iron out some of the challenges that will no doubt emerge from the work. So I think we've actually all got a role to play, and our recommendations were quite specific, but everyone has a part to play in this game.
Yeah. And did you get some phone calls after your article was published, guys, with people going, oh, I like your 7-point plan. Will you come on board and help us implement it?
No phone calls, Louise.
Okay. Well, we'll see if the podcast might be the game changer.
Even worse, maybe you got a fax asking for those information.
I actually got a page about it. No, I'm kidding.
Okay, guys, fast forward 10 years. Australia, we pull this off. So paint a picture for the Pulse Putties. What does Australian healthcare look like?
So 10 years is far too long to look ahead in anything to do with technology, as well you know it, Louise. I'll go for 5 years. In 5 years, it's reasonable to expect the HIE to be up and running, the scope of data that it is moving around and has access to, and in which case we should be running trials using AI and predictive analytics to keep people healthier at home, either particularly those that maybe come out of hospital and they've been diagnosed with a chronic condition. How do they manage themselves better and stay healthy? And then just looking further forward in 10 years, you would hope that that type of technology, using that data, would be available in people's hands on their mobile phones, helping them to make decisions about their own care, where to get care, who to get care from, what type of care they should get, how they can manage themselves better, and doing it in really personalized and tailored ways so that they can then access services when they need them.
I think that's an excellent response from Robin. I have one sort of just simplistic thing that I want to see from a HIE in 5 years' time. I want to talk to an intern who is on a urology rotation and have them say to me, I did not need to chase for a urine MCNS. Having a HIE will just fix that one simple problem, but it's representative of all these different problems that just grind our junior clinicians down day upon day. And not just junior clinicians, senior clinicians as well. I would love to be able to see information foraging reduced down to nil. And as Robin said, even predictive technologies coming through to enable clinicians to provide personalized answers from data all over the patient's journey, right there to them as they're speaking to the patient at the bedside or in their clinic room. So my short answer is no more urine MCSs, no more use of the word chase. And the larger answer is, of course, Australia being an innovation engine and this being a systemic fix for hopefully a lot of clinician burnout.
If I can just have one personal question for Honor. A lot of junior doctors have that same frustration. They get into medicine with all these great ideas. By 5 or 6 years of med school and then a couple of years of junior medicine, it all gets burnt out of them. What advice do you have for young junior doctors who want to be innovative, do exciting things to get to where we can actually have an innovative clinician system?
Yeah, absolutely. First of all, just follow your curiosity. So if there's something that sparks your interest on a Facebook post, a LinkedIn post, that's my second piece of advice, actually. Get on LinkedIn because LinkedIn is actually very interesting and very cool if you want to be working in the informatics space. And just talk to other people who are doing interesting things. That's how I got into this sort of role. The genesis of me taking my first step into informatics was cold calling my would-be boss in Metro South and saying, hello, I'm a junior doctor. I have a role advertised for someone, but could that someone be me? And they made a role for me.
Fantastic. Great advice.
Thanks, guys. That was excellent. I really appreciate, on behalf of all the listeners, you deconstructing your article for us. We will put a link to that in the show notes. Thank you so much for your time and sharing your thoughts with us.
It's great to see you.
Yes, indeed.
Now it's time for an update from our correspondent, Kate McDonald from the Pulse IT News Desk. Welcome to the PulsePod studio again, Kate.
Thank you, Louise. We must say we were watching the American election with complete horror last week, and that's pretty much dominated chat in the health IT sector. We must say we were a bit gobsmacked at the outcome, and we are very concerned about what we think will be a very bad influence on global healthcare if President-elect Trump lets Robert F. Kennedy Jr. run loose in the White House. He's already made his point clear about what he thinks about vaccines. We're also worried about cost-cutting measures. They all are planning that will mean that the US government perhaps even withdraws support for the WHO and for healthcare in poorer parts of the world. We think it's a big concern. We're also very concerned about people like Elon Musk and Peter Thiel. They'll be a disaster for technology policy as it affects healthcare. These guys are the geniuses with technology, but we think that they can be seriously dangerous in future. They're all in it for the money and the power. And the big pharma sector is rubbing its hands as well. One of the first reactions we heard from an industry group was from a big pharma lobby group about what's going to happen with the new administration. And they were saying that under the Biden administration's efforts to lower drug costs, innovation had been stifled. Yeah, it's a bit of a worry. It's innovation without the guardrails that has us worried. There was talk about removing mandates and red tape, which is what these people are all about. But what does that mean for mandates for interoperability and information blocking? And by extension, innovation in digital healthcare. If you remove those guardrails, what does it mean? Unfortunately, we think it'll be left up to the EU to be the rational actor in the world when it comes to things like legislation, regulation, particularly of AI as it pertains to healthcare. Leaving it in the EU hands is another thing, that's a known bureaucracy there, but we think they may be the rational actor. We polled our readers on this specific question on the weekend. Will AI regulation in healthcare be safe under the new Trump regime? 80% said no. The people who were in favour said, oh, he's a businessman. He won't do anything to stifle AI. We're a bit more worried about him running rampant. And when there's also serious concerns about the survival of big American institutions like the FDA, the US Medicare and Medicaid systems, and even the National Institutes of Health. Are they going to survive 4 years of Trump? Otherwise, there was some really good news that we've been following this week. There was a lovely story we had on how do we introduce virtual reality into aged care facilities using technology from Melbourne company Silver Adventures and the challenges that aged care providers have in using that technology. VR is particularly good for things like reminiscence therapy and dementia care, but VR uptake has always been a bit hampered by the things that challenge everything for aged care: technology, time constraints, technophobic staff. There are also basic things like keeping VR headsets clean. These are the sort of challenges that you hear great stories about how these devices can help aged care residents, but the practicalities are quite often something different. We also had a lovely story about using health screening booths and devices in pharmacies. There is the hope that using these sorts of health screening tools where you go into the pharmacy and you get your blood pressure taken, that it will tempt people who don't generally connect with the healthcare system to have a free screen for heart rate and blood pressure and a bit of a nudge to go to the GP. This technology is certainly nothing new, but the hope is that these sorts of devices are getting cheaper, they're being subsidised, and our story is about a trial of a free device in a pharmacy in a rural area where access issues are a concern. There was also a really nice story, getting back to the evils of Elon Musk. One of the great things he's done is the Starlink system, his satellite system, which is brilliant. And we had a lovely story this week from rural New Zealand where they're using portable Starlink devices to get around black spots in rural areas. And it's so powerful are these things and so affordable that you can totter around in your car if you're a visiting nurse or a GP in a rural area, have a Starlink box and be able to upload clinical notes while you're in a patient's house or while you're travelling around. That's a good news story from Elon Musk, I must admit. And in Ireland, there's a wonderful story going on at the University of Galway called the Home Health Project. And it's part of a bigger program called Healthy Islands. And that's taking place in a couple of the islands off Ireland's west coast. They've been trialling remote monitoring there as there's poor access to healthcare on the islands. And they want to extend that to see if they can make sure that appointments can be put in a dynamic scheduling of appointments so that those who need them can get them rather than a set schedule where you don't actually have to travel off the island. I love this sort of story. It's using AI to go through medical records, but using them on the remote monitoring devices to say, well, this person's blood pressure is up a bit. We'll get them in earlier than not regularly scheduled. That sort of thing is where AI can have a real immediate impact in conjunction with remote monitoring devices. I love this sort of story. What piques my interest in it is that I once spent a lovely holiday as an 8-year-old on one of the islands involved, which is called Inishbofin, which is off County Galway or County Mayo. And they were just getting the electricity hooked up back then in 1980. And the milk in our cornflakes still had bits of blades of grass floating around in it, straight from the cow. So it's come a long way since getting the lecky hooked up. And now they're doing remote monitoring and using AI to make sure that people don't have to travel off the island if they don't need to. It's just great stuff. It's lovely stories. So with all of the doom and gloom I started off with, there's still some lovely stories out there.
Oh, I love it. Thanks. That's a great selection of stories. Thank you, Kate. And some of your stories there at the last couple, Kate, reminded me, George, of your old boss. I remember seeing Eric Dishman give a talk when Intel was just going into Ireland to help them with, how they could do home monitoring types things, and talking about how they was, this was back, there was no wireless then. You literally had to have blue cables running through walls. And I remember him talking about how you would do that when you've got these walls that are like 2 feet thick, 1,000-year-old stone walls.
Solid stone walls, yes. Having said that, we did a project at St. Vincent's Hospital. We had exactly the same problem with their 2-foot stone walls. Look, anything that improves access is a plus. The reality is, biggest challenge we have in healthcare is that not everyone has access to all the services they could. So these examples are great. The Silver Adventures one, the VR one, is really exciting. I know Colin quite well. He was actually one of our ITAC winners a few years ago. Everyone thought, people in aged care facility wouldn't strap on a virtual reality headset. When you see these people using it and the look of excitement on their face as they go back through places, what they were like when they were young 60, 70, 80 years ago is unbelievable. So I think there's lots of opportunities here. Hopefully in 4 years' time, we'll look back and say, well, we survived Trump and now let's move forward. The world will be a better place. But I guess this is where we need to some degree play a much more active role in making sure we get the quality care that we need in this country and around the world.
Yes, we've got a representative from WHO on a future pod. It's a topic we need to think about. And thanks, Kate, for highlighting it, because it's a responsibility that we have, all of us who work in healthcare, for global health, whether that is in our own backyard or if it's in another country, to actually do everything we can as a technology and health community to ensure people have access to high quality care and improved health outcomes that are enabled through tech when that's a possibility. It is a really important thing. We need to keep an eye on that.
And maybe Kellogg's will start introducing some grass into their cornflakes to make Kate reminisce in her good old days as well.
It was the nicest bowl of cornflakes I've ever had in my life. It was gorgeous.
That's so sweet. All right. Well, we'll tune in with you in the next episode, Kate, and we'll see how the world has progressed in the next fortnight.
Hopefully it'll still be here.
So, George, we've come to the conclusion of another jam-packed episode 12.
Episode 12. 12 episodes of Pulse Pod, and in that time, the world has changed, the digital health has changed. We've done lots of interesting things.
Yeah, and we've gotten younger, of course, as well.
We have, and we can say that because we have no video display, so you can take our word for it.
Absolutely. Well, it's been a pleasure being in the Pulse Pod with you and with Kate today. So, George, if you can read us out, please.
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Nigel Chartres, Emily Mara, and Kate McDonald for contributing to today's episode. Subscribe, follow, and rate Pulse wherever you get your podcasts. You can subscribe to Pulse IT magazine at www.pulseit.news. Send your feedback and questions to pulsepod@pulseit.news. And don't send your images to Twitter.
Thanks, George.